Chairpersons. I want to start off by thanking Dr. Supriya for inviting me to speak here. It's a privilege and I'm very pleased. I also want to thank my colleagues, Dr. Robin Tamagura, who put together a video for me for this presentation, and colleagues across the country who have been very generous in giving me material to present. Professor Piyush Sani in AIMS, Prof V Kapoor in SGPGI Lucknow, and Dr. Sadiq Sikora in Bangalore. They've all been very generous, and you will see some of their material in my presentation. For postgraduates in the audience, I want to introduce this website. It's a question and answer website. You can post your questions and you will get answers from faculty across the country. It's a very useful online resource and I would urge you to have a look at it. Bile duct injury is a very emotive topic. It is always an iatrogenic condition, and it is well worth our while to study it and see what we can do about it. When one talks about bile duct injury, many questions come up. When you predict difficult cholecystectomy is one. Why do bile duct injuries actually occur? Can you prevent them? What about the intraoperative situation, recognition, treatment? The immediate post-operative situation, recognition, treatment? How do you classify bile duct injuries? What about early repair of bile duct injuries? A lot of reports coming up of late. How long do you wait in the situation of an external biliary fistula? Do you need to operate on bile duct strictures? Do you treat them with stents? What is a good hepaticojejunostomy if you are operating on them? What about strictures of the portal hypertension, which can happen in our country with neglect and poor socioeconomic status? Do you need to do a shunt before you do a hepaticojejunostomy? After you've done a hepaticojejunostomy, how long should you follow up? How should you follow up? What about bile duct resections and what about liver resections and bile duct injury? And lastly, quality of life in bile duct injury. I'm going to confine myself to the first three and then show you a short video where I hope we will learn a lot about what not to do. Can you predict difficult cholecystectomy? This is important because you may want to allot appropriate time in your operating list. You may want to choose the appropriate surgeon to do a difficult cholecystectomy rather than a novice who is just starting off in laparoscopic operations. I want to particularly emphasize, when you see the situation of thick wall gallbladder, one must keep in mind that this could be a carcinoma and appropriate investigations before that. So these are difficult situations and can give rise to a difficult cholecystectomy, and that could run into a bile duct injury. For members in the audience, I'm flattered that some of you are taking photographs of my slides. You needn't bother. This slide is in this computer, and I don't believe in intellectual property rights. If you want to take this and use it as you see fit after this presentation, I have no problems. So why does bile duct injury actually occur? I was fascinated by this paper, which is almost a decade old, but which discusses some very interesting factors that could cause bile duct injury. And the authors talk about a misperception rather than lack of judgment or skill or knowledge. There is a whole new way of looking at errors, and this is part of a branch of science called cognitive psychology, where we study how the human mind works. How do we process information? How do we process experiences? And perception is one important thing in the way the human mind works. And in cognitive psychology, we see the science of human error. One branch of cognitive psychology is the science of human error. Human error can be very costly in some situations like commercial aviation and nuclear power industry, and the impact on society is huge. So we need to limit the frequency and severity of unwanted events in these situations. And we have learned, as surgeons, we have learned a lot from the commercial aviation industry. I could think of offhand two things straight away. One is checklists and the other one is in simulation. In both of these, we have learned a lot from commercial aviation. So there are three groups of problems that can produce a bile duct injury. One problem, as I said earlier, is misperception. You see a tubular structure, you think it is a cystic duct, it is actually the common bile duct, and you deliberately divide that structure, thinking it is a cystic duct. It is actually the common bile duct. The second misperception happens when you are dissecting the callous triangle, and you think you are dissecting very close to the gallbladder, where in fact you are dissecting very close to the common hepatic duct or the right hepatic duct. These are problems of misperception. The second group of problems is in faulty decision making or knowledge. The database is not strong enough, and you've not followed the proper procedure to do an operation. Or, as you will see in the video, you're doing an operation that is not appropriate for the situation that is demanded of you. And the third one, obviously, is poor skills. You're clumsy at what you're doing. These are three main things that can happen during laparoscopic cholecystectomy, and they can give rise to bile duct injury. How does our mind work? For much of the time, our mind works by rote, by automatic processes that are not really reaching the conscious. And this is called heuristic process. We don't often think about many of the things that we are doing. We have rules of thumbs, we have intuition. You see a patient with tachycardia, you know the most likely cause is lack of analgesia or fever or fluids. So much of our life is by rote, by intuition. Most of us drive back from home in the evening, and the commute is largely blanked off unless something happens during that. We do it automatically. So that is heuristic thinking. It's not analytical thinking. It provides solutions most of the time, but sometimes it gives up on us. So that's important to realize. And visual perception is one such thing. We see a lot of things, but very few things we perceive, because what we see is filtered by the mind, and then some of that only is taken up into the conscious. And this is important in laparoscopic because this subconscious heuristics governs what we are doing. And we must try and break away from that at least partially in order to prevent bile duct injury. Let me explain. If you look at this picture, it's actually just a sprinkling of ink on a sheet of paper. But you can see a dog. Once you've seen this dog, you start imagining a pathway here and a pathway here. You start imagining a tree here and the ground that has been dug up around the tree. These are visual illusions, that tricks that the mind plays on us. And a similar visual illusion is this. Once you've seen the white triangle inside, you can't take your mind off from that white triangle. The white triangle is actually not there. It's a visual illusion. So when surgeons look at the hepatoduodenal ligament, they look at the undersurface of the liver at laparoscopy, you are unconsciously trying to match that up with an image that you have of what should be there. You are looking for a pattern that will match what is there in front of you. And this is the price we pay for heuristic process. we tend to err in the direction of the familiar and the expected. And when the unexpected comes up, we try to push that away from us. And that's what I'm going to show. We all have a confirmation bias within us. This is part of our life. We see a structure, we think it is a cystic duct, we keep moving, and then even when there are pointers to say that this is not the cystic duct, this may not be the cystic duct, we try to brush away those pointers, justify our brushing it away, and then move towards the fact that this is actually the cystic duct. It happens in our personal lives also. We have a colleague whom we don't like, whom we think is against you. You look for things to say, that is correct, my thinking is correct. Other things happen to say that the colleague actually likes you, we brushed it away. You speak to divorce lawyers, it happens all the time. Once the wife suspects the husband of having an affair, that's it, he's finished. Even if he's not having an affair, she is thinking about that all the time and she's looking for pointers to support her. Same with men. So, we tend to discount evidence against the confirmation bias. So we have to accept our human frailties. Laparoscopic cholecystectomy is a human activity. We probably will injure one duct in 1,000 cholecystectomies, which is the best as far as industry standard today goes. And we have to see how we can fight this innate heuristic bias and lower that and maybe avoid it altogether in our practice. To do this, we need to understand there is an input into what we are doing, and that input, unfortunately, is purely visual. There is no haptic involved in that as an open operation. There is a database that we have accumulated over a period of time, the long-term memory, training, whatever we have had, whatever we've seen other people doing, and put both these together, we have human thinking, but much of this is in the subconscious. And then that human thinking results in an action, and that action is a laparoscopic cholecystectomy, and hopefully it will be a laparoscopic cholecystectomy without bile duct injury. In the UK today, if you injure 2 bile ducts on the National Health Service, you are sent off for training, retraining, before you are allowed to do a laparoscopic cholecystectomy again. And on the private side, you can't do laparoscopic cholecystectomy after you've injured 2 without that retraining. So it hurts your pocket. But is that the solution? The corrective strategy often lies outside the individual. There has to be a system change. So what could possibly be that system change? You could change the process. One change in the process that I can think of is that you could call a second surgeon who is operating the adjoining theatre to come and have a look at your anatomy and say, okay, I agree that this is a cystic duct, before you clip and cut the cystic duct and cystic artery. That could be a process change. Or you could use technology in the form of intraoperative cholangiogram to make sure that your biliary anatomy is right, what you're cutting is actually the cystic duct and not the common bile. So the change generally has to be outside the individual and not within the individual in order to prevent bile duct injury. How do you prevent bile duct injury? So obviously the first thing you've got to understand is that you need very good optics. You need a 30-degree telescope to mimic what you see at open operation so that you have an anterior-posterior view and not a view from the pelvis. You need good optics so that you can see what is happening. Lateral traction on the infundibulum would prevent the cystic duct and the common bile duct going up in the same straight line. If you pull the infundibulum laterally, you create a right angle between the cystic duct and the common bile duct, and this would prevent bile duct injury. I've already talked about on-table cholangiogram, and the second opinion is spend a little bit of time on critical view of safety described by Strasberg. It is not just an isolation of the cystic duct and the cystic artery in callous triangle. It is not creating windows between these two. It is also important to understand that the critical view of safety means the base of the gallbladder, part of the base of the gallbladder near the cystic plate, is taken off the liver bed. If you can't get critical view, you should convert. So this is critical view of safety. The callous triangle has been completely denuded of all fat and fibrous tissue. Only two structures remain, the cystic duct and the cystic artery. And here you see part of the gallbladder has been dissected off the cystic plate. And this will show you that there are only these two structures, and you cannot be in a situation where you are cutting the common bile duct thinking it's the cystic duct. What is the other technique that is commonly used? The infundibular technique. Infundibulum means funnel, and you identify a tubular structure which you think is a cystic duct. You follow that structure towards the gallbladder. It flares out into a funnel, and you think that is definitely the cystic duct. So what is the pitfall in this technique? The pitfall in this technique is that the common bile duct could be very densely adherent to the gallbladder, and this picture that you see could actually be this. What you are seeing as a cystic duct could actually be the common bile duct. So this is a danger in the infundibular technique, and this is not possible in the critical view of safety. You will not be able to get a critical view of safety once you isolate the tissues in the callous triangle and take the gallbladder off the cystic plate. There are pitfalls in cholangiography. There is a large body of evidence to say that cholangiography helps to prevent bile duct injury, but there are pitfalls. Images may not be properly appreciated. Cannulation of the common bile duct by accident may not be entirely innocuous, and it's very difficult to make out right hepatic duct injury in cholangiography. So, if you cannot demonstrate critical view of safety, convert to open. Open the serosal aspect of the gallbladder, remove all stones, ligate the cystic duct from inside. Conversion to open operation is not failure. Inability to remove entire gallbladder is not failure. Common bile duct injury is failure. I'm going to stop here and show you a video of one of my patients. She came with this video with a bile duct injury, and I'm going to show you that, and hopefully we learn something from